It's our annual healthcare conference. The Department of Insurance has been sponsoring an annual meeting of interested parties, agents, insurers, consumer groups, all gather for one full day of discussion of health insurance and the challenges and issues that it presents. Never more so than the past 5 years in the aftermath of the passage of the Affordable Care Act. But we get lots and lots of really up-to-date, valuable input that is very helpful to me as a regulator and to agents representing their clients as well as the companies that they write for, and a feel for what the future holds. I hope that people will leave here better informed and with some fresh ideas. I always say in insurance, we always are trying to make it more affordable and available to policyholders, to consumers. And there are no silver bullets to make that happen. It takes a lot of Band-Aids to fix a broken property insurance market, as we in Louisiana experienced a decade ago in the aftermath of Katrina and Rita, and a health insurance market that has been in disarray for the past 5 years, not just in our state, but in every state in America. Frankly, we're one of 11 states that are seeing rates decrease this year in the individual market after 2 years of a combined 50% rate increase for those folks. They have been dropping out of the market, going uninsured if they weren't eligible for a subsidy to offset that spiraling cost. And most employers are no longer providing health care to their employees because of that increasing cost. So certainly a challenging time, and hopefully this all-day gathering with the impressive array of presenters that we have to offer will offer some ideas and suggestions for improvements in the near future.
Thank you so much. There is an annual meeting of the Department of Insurance and the Louisiana Healthcare Commission sponsor every year, where you can convene everybody in healthcare to talk about what's happening in healthcare, what the possible changes are, what needs to be tweaked or changed, what needs to go forward in terms of new policy. A lot of questions unanswered. The midterm elections, for example, I think are going to be front and center in our discussions today, and what that could mean in terms of changes in national healthcare policy if the Democrats take over the House. What's that going to mean in terms of how we go forward in a bipartisan spirit. So I think it's a really interesting day and lots of challenges. We're talking about budgetary considerations and how that impacts the cost of health care. I think one of the most important things to come out of today is the fact that Louisiana is one of 11 states that's actually going to see a reduction in premiums. And that's a good thing. Thank you so much, John. That was a very sweet introduction, even though you're married to me and know me better than any of you. Most of you in the audience have been here before, I think. Why don't you raise your hand if you have? Oh, wow. So you're an alumni association of this meeting, which, by the way, is in, I think, our 26th year, although they haven't been all contiguous years. So it's very, very special that we have this meeting year after year. Look forward to seeing each other, sharing ideas, asking good questions, and more particularly getting your CE credit for being here. At this time, to introduce a man who probably needs no introduction to you, because I guess at some point, and I don't know if we're there yet, Jim Donelon will be the longest-serving commissioner of insurance in the state of Louisiana, and perhaps will be reelected and will be the longest-serving insurance commissioner. Commissioner Donelon was first appointed in 2006, and then he filled an unexpired term and reelected to 3 consecutive terms. Without further ado, I think one of Louisiana's most important public servants and important leaders, Jim Donelon.
It's very, very gratifying to me to have the opportunity to be here with John and Donna, to be here with so many of you. That show of hands really reinforces the fact that we have benefited from this interaction, from this day of dialogue, from these very impressive presenters that once again today will share with us what's happening in an ever-changing and very challenging part of our lives, and that is health care and health insurance to provide for the cost and to protect folks with their need for the ability to access health care through health insurance.
The message that I'm speaking about is regenerative medicine in the workplace and with self-insured companies, specifically in orthopedic injuries and orthopedic issues. So this is a disruptive technology that continues to grow, and I think it's a very important topic that the insurance industry needs to hear about. Really excited to be here and talk about a topic that I'm very passionate about, that I hope that some of you guys have heard of before, and if not, then you will now hopefully hear about it and be as passionate as I am. Today's talk is cost effectiveness in regenerative medicine. And so what are some of the issues or some of the problems within the current state of patient flow or the injured worker, whether you're talking about a self-insured company or through the workers' comp process? One is that it's incredibly expensive. In Louisiana, we certainly know that, as the data would show, that Louisiana's the highest indemnity costs in all the other southern states. We know it costs a lot of money to have surgery. We also know that having surgery puts a bind on the company as well as the worker. Everyone is aware of the problem in this country with opiates. Louisiana is no exception, as Louisiana, as per 2013, ranked first in opioid prescribing. And this is an absolute epidemic, as you can see in the next slide, all over the country. We've got opioid use is out of control. That's starting to be curbed through regulation, but it's still a massive problem. So for all of you that in this room, if I could ask you the question of if I said, what's your wish list? What's the best case scenario from your perspective of this patient, this worker, this employee that just got injured? What would be some of the things you might say? You might say, well, what if we could get that worker better and back to work without any opiates, and save and in it with a process that saves money for the employer? Some of the techniques that we can do that potentially replace surgery are ligament stabilization procedures, growth factor injections. How many in this room has heard of PRP, platelet-rich plasma? Show of hands. Wow, okay. I guess I'm not advertising enough. I saw about 4 hands. So platelet-rich plasma is a growth factor injection that's called autologous, or from your own body. So does anybody here have a shoulder problem? There's one there. Okay, now we have some hands. So if you go to physical therapy and that physical therapy doesn't work and you still have the shoulder problem and you get an MRI and it says that you have a partially torn rotator cuff, you have, at this point, one of 3 options. 1, you can do nothing about it and suffer until it tears. 2, you can go and get your shoulder scoped and have a minimum 6-week healing process in a cast-looking thing like this, where you have to sleep in a recliner, or you can have regenerative medicine and have none of that. So this is something that affects everyone in the room, either from a clinical perspective for you or someone you know, or from the insurance perspective. So I'm glad I'm here. So growth factors, platelet-rich plasma, you have the healing ability in your body, in your blood. How many people have cut themselves before and it healed by itself? You didn't have to go have surgery for it, right? This pretty much happens every day. Your body wants to heal you and is trying at all times to heal you.
I think the main message today is for all the Louisiana stakeholders to know that data are their friend, and that we can support them in all the initiatives, whether it's a state regulatory or whether it's a business development or innovations. Data is always key.
Our message is how to bring price transparency to health insurance and costs. So we have a lot of data that helps everybody involved in the healthcare industry understand what costs are and what utilization is, which helps a lot of people make different decisions and brings transparency, helps consumers, and it can be really used across the spectrum of healthcare.
Good morning. First of all, thank you so much for having Chris and myself join this panel, because that was very innovative. When we're talking about innovation, we're talking about all the various things in the industry. I mean, we all have an interest, and that's ultimately helping the patient, the consumer, helping that patient get access, getting good quality care, and keeping costs down. Innovation is a word I was mentioning earlier to Marcy. I said, you teed it up for me. We have so many things that we could talk about. But innovation is one of those things that's really overutilized in the terminology, because everyone is innovating. Everyone on a daily basis is really trying to work towards that goal of helping that patient with access and affordable care. So one of the things that Fair Health does, and you've heard it mentioned in the bios, we are a not-for-profit organization that's independent. And when you're looking at the GeoZips here, note that we have 7 different regions within Louisiana versus Medicare. Medicare has 2. That just splits it out. So in other words, if you're really wanting to get into the differentiations between Shreveport, Monroe, Alexandria, Lafayette, you can really get down into that level of detail versus having to stay at the 2 areas, which are the 2 main regions across, I think, right at I-10. And then you look at the CMS. We are also one of those fortunate organizations that we earn the right to take in all of the Medicare data at a claim line level data. A lot of people say, well, we have Medicare data. Yes, you can, and you can get access to it. But we are one of the stewards of data that actually gets down to the demographic information for Donna Smith, understanding all of my claims, and we put it in the repository so that we can also embed it in these type of studies for the good of the consumer and looking at the trend lines.
Thank you. Okay, so now I'm going to talk a little bit more about the nitty-gritty pieces of how the data are used and how they're put together to show you that it is robust and how it might support different kinds of decisions you may be making in your day-to-day operations, or how it can impact your interactions with consumers, patients, and providers. We can also do custom work so that if you want information as an aggregate for the state of Louisiana, we can do that. Or if you want information for urban areas or rural areas within the state, or you want to look at 3 states or whatever, we can, because we have the granular data, we can recombine it to do what you're looking to do with it.
He is certified by the American Board of Surgery. Please help me welcome Dr. Richard MIGLIORI.
It's really a privilege for United Health Group and its entities, particularly United Healthcare, to be able to participate in the service of the people of Louisiana. This is a very competitive environment, and that competition breeds excellence. And we work hard every day to preserve the privilege of being able to operate here. So thank you, Mr. Commissioner, for giving us that opportunity and for this privilege today. So this is a little awkward for me. I'm a surgeon, as you see, and I'm not used to using a podium. And in fact, we didn't do public speaking. And podiums are just out of the place. Now, a pedestal, that's a different ball game. But a podium, no. So suffer with me. Listen, what I wanted to talk to you today about is something that is relevant whether you are somebody who delivers health care, whether you are somebody who purchases health care, whether you are somebody that insures it, administers it, but most importantly, for everybody in the room, as a patient of the American healthcare system. And what I wanted to show you is something that, with all the change that goes on, and all the different ways in which funding systems may change, when I get to this side of my career, I want to leave people with something, and that is never, ever, ever take your eye off the ball on the quality of care that's being delivered. When you fix a problem right the first time, and you don't have to redo it, It is the cheapest way to deliver health care. So look for quality. It will tell you where your cost savings are. The third one is this, is why not, if you're able to help people accessing care, and you're doing it because you're getting all this information out of the health system, why not be a good person and package it up and give it to their doctor? So that way, when the patient comes back and goes to see their physician, and we've done our job in giving the doc the information, then the doc can be at the top of the game, focused on the patient, not have to be looking around to go find data about the patient that they have to spend so much time trying to collect on their own. Give them access to the data they created. They're very smart. They'll do the right thing with it, especially if you pay them for doing the right thing with it. Now, in order to do this kind of work, you have to have 3 types of capabilities within the company, within the asset, right? First one is you got to have some clinical insight. In other words, you got to know how medicine works, all right? So you need some clinical insight. So the first thing, how do we handle with that? There are 86,000 licensed clinicians at United Health Group. 40,000 physicians and just a few more than that nurses. All right, what's the job? To describe what's in that healthcare system and to coordinate its activity. Additionally, we got about 35,000 docs who work in the company who actually deliver care. The second thing that we have to be able to do is to manage those trillion transactions. So we have 28,000 people whose day-to-day job is keeping the lights on. Now their job's a little harder because they got to make those transactions occur reliably, fast, cheap, etc. And just like the roadies at a rock concert, they have to be invisible. They got to wear black, all right? Because nobody can see them. We want to be taken for granted. When you have problems in that area at 32,000 a second, you create big problems for people's lives. You can't afford to do that.
My message for today is to let folks know that the administration has been creating some alternative coverage options under the Affordable Care Act and help them understand how that's affecting health insurance markets in Louisiana and other states.
He previously served in the Center for Consumer Information and Insurance Oversight of the United States Department of Health and Human Services and was with the Center for Children and Families at Georgetown University's Health Policy Institute. Please warmly welcome Mr. Joe Tesher.
Glad to be here. This is my first time in Louisiana and first time at a Louisiana healthcare conference. So I am pleased to be here, especially because Commissioner Donelon is such a fair referee for the insurance industry. So that really gives me confidence that I'll be able to get through this presentation without getting flagged for targeting. So I'm glad for that. Heading into open enrollment is just about a week away, right? Looking at where we stand in the exchanges. So looking at just the 39 states that use healthcare.gov, obviously Louisiana is one of those states. We are seeing new issuers, new entrants to the exchange markets for 2019. You can see that in those 39 states, we have 23 new issuers and 29 issuers who are expanding their service areas. So maybe we don't have United in Louisiana this year, but we are seeing some new entrants across the country. It was a fairly brief time when the 90-day limitation was in effect, right? So that old rule went into effect on April 1st or was enforced after April 1st of 2017. New rule comes in October of this year. So it was really less than 2 years that that short-term plans were limited to only 90 days. So now that they're back up to 12 months, I think it's important to remember we're not going back to the pre-ACA days. We're not going back to 2013. We're going back to the way things were before April of 2017.
We want to make sure that consumers have cost-effective, clinically effective access to prescription drugs. And we as regulators have to efficiently and fairly balance the interests of all parties, consumers, the regulated entities, the insurance companies, and manage that relationship with pharmacies as well.
It's important to manage the benefit because I know everyone in this room doesn't want to pay for it. I know folks don't want to pay higher taxes for these kinds of things when government groups can no longer afford insurance. We need to keep these tools available for employers and premium-paying policyholders so that we can have affordable benefits and we can afford the innovation that we want, our family members want, and that we all deserve to have.
I represent the Louisiana Independent Pharmacies Association. It's 460 community independent pharmacies. These drug prices are something that is of tremendous and significant concern to the pharmacies because, after all, the very first time that these drugs are purchased, they're purchased by the pharmacist from a manufacturer or a wholesaler, and he's putting them on his shelf. When we look at these things like Durexis, it's on the Medicaid formulary. It takes some prior authorization to get it, but it's on the formulary. It's $28 per tablet on the formulary, and it's probably over the counter maybe 25 cents to do those two, to combine those two. So those things are of significant concerns. What happens with those pharmacists with those discount drug cards is if they process using that group and bin number, it goes through a secondary processor and goes through there, and they typically have $4.95 to $11.95 that gets taken out of their remittance there in a month or two about that. So there's no great benefit for them to take that card. They can usually find the opportunity to help their patient. There are different applications out there, like GoodRx is one of them. There's a few different things on the internet to advise you what the lowest costs of drugs are. We passed a piece of legislation in 2016, which was the start of part of this gag clause legislation. And that piece was going to give the opportunity for us to start working on the gag clause. We started with what we ended up with this year when the commissioner of the Department of Insurance came with some legislation. And that piece, as we migrated through it from 2016 to this year, we've seen not only that it was passed in Louisiana, it's been passed in approximately half our states. Congress passed it and the president signed it last week or the week before in a piece of legislation that one of the chief co-authors was Louisiana Senator Bill Cassidy. I think Susan Collins from Maine was the chief co-author. What that particular piece of legislation allowed was that when a pharmacist has an interaction with that patient where they see that the copay is going to be a greater amount than the pharmacy reimbursement, then they can advise the patient of a less costly alternative to using their insurance on that.
I'm very proud of the team that I work with at the Department of Insurance. Many of them have been here today. You've met some of them, and I hope you will feel free to reach out to them or to me with any ideas, suggestions, recommendations, complaints you might have. We can only do and do it better when we know what's going on out there.